Hi, I'm Dr. Priya Kumar. I'm a GP and Health Inequalities Lead for Slough. So this morning we were talking about health inequalities and how we can have practical solutions at primary care level. So we talked about all the different strategies we put in place. I work within the Frimley ICB patch, and 70% of the underserved population lives in Slough alone. So as Health Inequalities Lead in Slough, I've been able to do practical solutions in supporting our communities in a different way. We work with lots of our partners across the system, both primary, secondary and tertiary care, as well as the voluntary sector, local authority. And our biggest assets are our patients, who tell us how they want to base. Our biggest assets are our patients and how they want us to reach out to them. We talk about hard to reach communities, but they don't really exist. Our services are hard to reach. We were talking about the practical solutions in primary care where we can basically move our services to our people, that reach out programme. So last year in Slough we embarked on a new project and that was within health with our social prescribers. We wanted to empower them within our primary care settings, and we went out and spoke to about 3,300 individuals living in these underserved communities. And we asked them 16 questions. Can you pay your household bills? Can you put food on the table? Have you got access to internet? And through that, we basically were able to see the problems that our communities were facing. So we had many populations, around 1,000 people came back and told us they have fuel poverty issues. So we've set up a fuel poverty line now where they can ring up and get support, basically to help their whole household. 290 people told us they had food poverty issues. We referred them to the food banks. 1,400 people told us they have mental health and isolations. And you wouldn't think of that in a multi-generational household, but it actually really does exist. And now we're working with talking therapies to make culturally specific mental health services, which are at practice based. You know, many of our cultures get worried about seeing their neighbour or their sister-in-law in the mental health trusts. And therefore, when they come into practice, nobody knows which room you're going to and what service you're basically going to see, and therefore we're trying to destigmatise mental health within our communities to really start to support them in a different way. So Upland has been really powerful for me as a conference. Now I know there's many more people that understand the needs of these communities, and I've really resonated with the group as well as the people, and I really fundamentally believe we can, create scale at change. We can create change at scale. If we work together, this could be a movement for our people to basically really address the health inequalities and health inequity that we see across the NHS. We are all patients ourselves, but we have the communities, we have the connections, we're connected with the voluntary sector. I mean, Jaspreet was just inspirational in what she told us today. And she said it perfectly. We don't need titles to do this work, and that's what UPNA is giving us. All of us, this is all our agendas, and we can really make a movement. I think what we can create, as I said, is scale. So if we can really show that as a group we are doing something for our people, as well as within the workforce, and collectively, if we come together around a few ideas and then say, hold on, we spread this nationally, and look, we're doing it everywhere across the country, that becomes really powerful, and then see the change. Because as many of us have said, we need to take a population health approach to this. And if we start to look after the 20% that really do need that outreach program, we're just going to make it better for the 80% of us, and really realign our resources. And we need to get that message out to those with the power for us to empower us to do what we do best with our communities. Taking us back to COVID-19, so in my own practice I have 5,300 patients, 96% of which are from a BAME background. I lost 14 patients in the space of 2 weeks, and that hit me really hard. I usually lose about 14 patients in a year. And then since then, I can just see the disparities our people are having, the worse outcomes, and it all starts from childhood. And how can we facilitate that family change? And I can see how we can do it collectively now. And there's a clear pathway and clarity and thought for us to really implement change. So I'm really passionate about trying to get as many people on board with this agenda for us to really facilitate that change we need in these communities. But also, it may sound a bit too far-fetched, but how do we start to work in the environment where we're in this financial crisis where we're in this post-COVID recovery, where our communities have suffered even more. And I think it's just all that drive of COVID has significantly caused more harm to our communities, and there was an imbalance previously, and that's even got widened. So now if we don't start to solve that, no one will. And we need to just get as many people on board with that messaging. And we all need to just do a little bit more, 10% more. And that's asking for a lot because all of us are doing a lot, but just 10% more of your time and focusing it specifically on these communities to really make the change.